Good morning, good afternoon, and good evening. A special thank you to the ISMRM and SMRT organizing committees for inviting me to present today. My name is Joseph Wu. I'm an assistant professor at the Department of Radiology and Biomedical Imaging at UCSF, as well as Director of Advanced Imaging Technology at the San Francisco Veteran Affairs Healthcare System. Today, it is my pleasure to share with you some of the physical advantages of imaging at 7T, as well as some successful strategies for getting the most out of your 7T system. I will be covering some of the clinical and basic neuroscience motivations for 7T MRI. I will also touch on some of the successful strategies and upcoming developments for brain imaging at 7T, based on work from the Human Connectome project and Brain Initiative Next Generation 7T projects. The first motivation that usually comes to mind for 7T MRI is higher spatial resolution. This comes from the linear relationship between SNR, field strength, and voxel volume. For example, if we double our field strength, we expect to be able to halve our voxel volume while maintaining the same SNR quality of our data. The higher SNR and spatial resolution available at 7T promises to provide more precise and earlier diagnosis of disease, as well as better treatment planning and treatment monitoring. The example T1 weighted images shown here illustrates the benefits of 7T. Impressively, we are able to reduce the voxel volume by a factor of 3, from 1 mm isotropic down to 0.7 mm isotropic, while increasing the scan time by just 30%. Furthermore, from these images, you can see that contrast between tissue types can also improve at 7T. One reason for this increase in contrast is the general lengthening of T1 as field strength increases. In the case of time-of-flight MR angiography, longer T1s help improve tissue background suppression. Comparing the 3T and 7T MRAs shown here, you can see an increased number of vessels at ultra-high field, including the lenticulostriate arteries, shown by the arrows, and the insular branches of the middle cerebral arteries, shown by the large arrowheads. Another potential source of increased contrast at 7T is the enhanced magnetic susceptibility effects at higher field strengths, resulting in shorter T2 star values of venous blood. As you can see here, the contrast between the paramagnetic venous blood and the diamagnetic brain tissue increases greatly from 3T to 7T. Together with the increased spatial resolution available at high field, the average resolvable vascular tree length, as well as spatial detail, increases substantially at 7T. Given the resolution and contrast benefits of 7T MRI, there are quite a few promising 7T clinical applications. For example, epilepsy is a neurological disorder that can be particularly challenging to diagnose precisely, and thus a prime candidate for benefiting from 7T. In fact, the ability to detect epileptic lesions can have a huge impact on treatment outcomes. Telezento and colleagues found after reviewing 40 journal articles covering roughly 3,500 patients that the odds of being seizure-free after surgery were 2.5 times higher in patients with lesions detected on MRI or histopathology. As such, there is growing interest to scan epilepsy patients at 7T, especially those who appear normal at 3T and who aren't successfully treated with anti-epileptic drugs. In collaboration with Dr. Pratik Mukherjee at UCSF and the San Francisco VA healthcare system, we are already seeing benefits from 7T in terms of improving the diagnosis of epilepsy. In this example, the clinical 3T T1 weighted MRI of a seizure patient was initially interpreted as normal. However, a follow-up 7T scan revealed bilateral posterior subcortical band heterotopia, also known as double cortex, which is highlighted by the red arrows. In this case, the 7T data helped the treating physicians confirm their decision not to pursue surgical treatment. Another potential application of 7T specific to epilepsy is the imaging of perivascular spaces, which play a role in waste clearance in the brain. Perivascular spaces are small cerebrospinal fluid-filled areas between blood vessels and the pia mater, which appear as small hyperintense features in high-resolution T2-weighted MRI. Feldman and colleagues at Mount Sinai Hospital leveraged the improved resolution and contrast at 7T to visualize and count the number of perivascular spaces in epilepsy patients. Detected perivascular spaces are denoted by these short green lines. What Feldman and colleagues found was that spatial distribution of visible perivascular spaces was most asymmetric and in fact fewer in the suspected seizure onset zone. In comparing 20 epilepsy patients to healthy controls, they also found that epilepsy patients have significantly higher degrees of lateral asymmetry in number of detected perivascular spaces. These results suggest that 7T imaging of perivascular spaces could serve as a biomarker for epilepsy. 7T T2-weighted imaging has also been used to study the role of perivascular spaces in Alzheimer's disease. Tsai and colleagues at the University of Illinois at Chicago developed quantitative algorithms to automatically segment the small hyperintense perivascular structures in order to robustly quantify the white matter perivascular volume densities. In doing so, they found a significant increase in perivascular space density in AD patients compared to age-matched healthy controls. This is thought to be due to perivascular space dilation in AD patients. Interestingly, in comparing perivascular maximum intensity projection images of AD patients with a typical diffusion tensor tractography, Tsai and colleagues found that the perivascular space structures appear in parallel with white matter axons. In 2016, the North American Imaging in Multiple Sclerosis Cooperative published a seminal paper in Nature Reviews Neurology on the central vein sign and its benefits for diagnosing multiple sclerosis, especially in the presence of disorders which can mimic signs of MS. Here is an example comparing a migraine case to MS at 3T, and you can see that both have hyperintense white matter lesions. However, looking closely at a fusion of T2 star and flare images, you can see in the MS case on the right a central vessel in the hyperintense lesions, but not in the migraine case. Importantly, the dark veins are located centrally in the lesion and can be visualized in at least two perpendicular planes, as highlighted by the arrows in the magnified axial and coronal views. As we work towards earlier diagnosis of MS, 7T can play a significant role given its higher spatial resolution and improved T2 star contrast. Here, Dixon and colleagues at the University of Nottingham demonstrate both the importance of scan parameter optimization and higher field strength in detecting the central vein sign in smaller lesions. The blue curve shows that the traditional isotropic 3T T2 star protocol is not able to detect the central veins in smaller lesions. After optimizing the voxel dimensions and echo time, their optimized 3T protocol, shown as the red curve, was able to do much better, while the optimized 7T protocol green curve was able to detect 40% more of the smallest lesions. Now that we've covered some of the clinical motivations and applications of 7T MRI, I wanted to take a brief moment to share some of the basic neuroscience motivations, not only because this is an area of research I am passionate about, but also because it is these basic neuroscience projects, like the Human Connectome project and the NIH Brain Initiative, which have helped mature 7T MRI technology to achieve FDA approval and subsequent clinical applications. Furthermore, these motivations continue to enable the development of next-generation 7T MRI technologies. From a more basic neuroscience perspective, one of the motivations to achieve 0.5 mm or smaller resolution is to resolve the mesoscale neuronal organization of the brain and to probe neuronal function at this scale. This should be feasible using blood oxygen or blood volume sensitive fMRI techniques, since optical imaging techniques, also sensitive to blood oxygen and volume, have mapped the mesoscale neuronal organization in macaque monkey visual cortex. To put mesoscale into context, the large macroscale refers to traditional resolution of fMRI that is performed around 1 mm voxels or larger. At this scale, we can only resolve large regions of interest or coarse patterns of brain activity, like the retinotopic mass shown in the upper right-hand corner. At the microscale, we're talking about imaging at 100 microns or smaller, at about the size of individual neurons. The mesoscale bridges the macroscale and the microscale, which opens the door to investigation of neuronal subunit organization, including cortical columns and cortical layers. By leveraging current 7T and other synergistic technologies like high-density array coils, 0.8 mm pre-mesoscale fMRI has already begun to probe neural processing as a function of cortical depth, and has recently developed into an entire field of its own known as layer fMRI. Through layer fMRI, one can assess the directionality of information flow between brain regions, given that feed-forward input, like thalamic sensory input, tends to terminate in the middle layers of cortex, while cortical feedback tends to terminate in the superficial and deeper layers. Now that I have hopefully piqued your interest in using 7T for your research and clinical practice, I want to share with you some of the acquisition strategies for getting the most out of your 7T system, given your needs. At the beginning of the talk, we covered the trade-off between SNR and spatial resolution. Another primary consideration when optimizing a scan protocol is the spatial temporal resolution trade-off. That is, if you want to go to higher spatial resolution, it generally takes longer to acquire. If higher resolutions are desired, time may become the limiting factor. To achieve higher spatial temporal resolutions, there are advanced techniques which can be utilized. For example, in-plane accelerations like grappa, or slice accelerations like simultaneous multislice, aka multiband. Both of these technologies take advantage of multi-channel receiver array coils and can be combined in amounts tailored to your experimental needs. For diffusion MRI, another parameter that plays into protocol optimization is the Q-space resolution trade-off. This refers to the size, the number, and the sampling density of diffusion B-value shells. Ultimately, the optimal acquisition strategy will depend on your scanner hardware, such as your field strength, gradient performance, array coil density, and V1 transmit homogeneity, which can be improved using dielectric pads or parallel transmit technology. The optimal acquisition strategy will also depend on how much scan time you have and the specific spatial temporal resolution needs of your study. This is why I often encourage my collaborators to take some time to pilot their options before beginning a large study. In the context of the Human Connectome project, here we evaluated the spatial temporal resolution trade-offs for resting state functional connectivity in terms of the number of signal ICA components supported in 2 subjects. Each data point shown here represents 1 hour worth of resting state data per subject. In the first 2 columns, you can see that going to 7T supports 15 to 20% more components. Going to higher spatial resolutions lowered SNR and required longer repetition times, noted at the bottom here on the x-axis. Thus, going to higher spatial, lower temporal resolutions tended to result in fewer number of supported signal components. However, an optimal trade-off between spatial temporal resolutions and acceleration factors was found by reducing in-plane acceleration from 3 down to 2 and increasing multiband accelerations from 3 to 5. This facilitated an impressive 1.6 mm isotropic resolution with a TR of 1 second at 7T, with improved performance over the best 3T protocol with voxel volumes twice as large. In addition to a number of signal components, we also looked at the effect of field strength on resting state bold contrast to noise ratio. Using our 3T and 7T optimized resting state fMRI protocols in the same set of 24 subjects, we found that by going to 7T, resting state contrast to noise ratio increased by a factor of 2 on average across the brain. Similarly, by going to 7T, we found significant increases in sensitivity to connectivity networks as evaluated by seed-based connectivity metrics. Here we show the correlation-based connectivity metric at 3T and 7T with a seed in occipital parietal cortex, again, averaged across 24 subjects. In the context of diffusion MRI, being able to resolve fine-grained structural detail can be even more important. Here I'm showing fractional anisotropy maps at 3T and 7T. By going to 7T, we're able to achieve a factor of 4 smaller voxel volumes compared to traditional 3T resolutions and resolve fractional anisotropy in the gray matter, as well as dark bands of fractional anisotropy at the gray-white matter boundaries, highlighted by the red arrows. Both of these features are typically not visible in traditional 3T data. Interestingly, these dark bands are not visible in the gyral crowns highlighted by the red arrows here. By overlaying the principal diffusion direction vector map, we can see that the dark bands of fractional anisotropy are likely a result of white matter fibers turning sharply into the cortex, mimicking isotropic diffusion. The dark bands do not occur at the gyral crowns, likely because the white matter fibers just continue on straight into the cortex without turning. Clearly, high-resolution 7T diffusion imaging is important for resolving complex diffusion properties, including in the gray matter. Another example highlighting the importance of high-resolution 7T diffusion imaging is in gray matter-seeded probabilistic tractography. Here, the seed is placed on one of the banks of the calcarine sulcus. The higher resolution available at 7T enables tractography to the opposite bank of the calcarine as well as to the ventral and dorsal projections of the visual system. That said, there are some aspects where 3T tends to do better than 7T. In the case of scans requiring large flip angles, like spin echo-based diffusion MRI, the shorter wavelengths at 7T tend to result in low flip angles in the ventral temporal lobes and thus weaker structural connectivity strengths. On the other hand, the lower resolution at 3T can result in some spurious false positive connections. One solution to get the best of both worlds is to combine 3T and 7T datasets in a Bayesian framework like Rubik's, as shown here. However, not every study can afford to acquire and combine data from both 3T and 7T, so it's important to look at alternative solutions for addressing B1 transmit homogeneity at 7T. Here on the left are some example slices showing how the center of the brain at 7T tends to have the highest flip angles, while the ventral temporal lobes and cerebellum tend to be drastically underflipped. This translates to low SNR and low tissue contrast in large flip angle imaging, like the spin echo EPI examples shown here on the right. To address these issues, there are two common solutions: passive B1 shimming using dielectric padding, which cost on the order of hundreds of dollars, not too expensive. On the other hand, we have parallel transmit, or PTX, as an alternative active shimming solution. While 2- and 8-channel PTX systems are becoming more readily available, they are typically much more expensive of an upgrade and can require custom or works-in-progress pulse sequences to achieve their full potential. Dielectric pads are not yet widely commercially available, but contact your scanner vendor for potential options. If you'd like to make them yourself, it's not too difficult. We make them from scratch in my lab using a 3:1 mass ratio in heat-sealed food saver bags. The Human Connectome project also used them, particularly the calcium titanate variety, since they are chemically inert and non-toxic. However, for larger B1 effects, you may want to use material with higher relative permittivity, like barium titanate. By just placing 2 calcium titanate pads behind the neck, one on each side, you can already see significant improvements in spin-echo API image quality in the cerebellum and ventral occipital temporal lobe. Quantitatively speaking, the flip angles in these regions roughly double, and the SNR quadruples. For improvements in the ventral temporal regions, you can also place additional dielectric pads on each side of the head as well. While dielectric pads help locally in regions next to where the pads are placed, they do not fully address the large difference in flip angle between the center and peripheral regions at 7T. Addressing this is important for large field of view imaging and requires parallel transmit technology. Current 7T systems do come with optional 8-channel PTX technology, such that each transmit coil can be optimized with a distinct amplitude and phase, or even its own waveform, to achieve much more homogeneous B1 distributions, as shown for this T1-weighted MP Rage. Subsequent work from the University of Minnesota and the Human Connectome project have developed PTX technology for spin-echo diffusion imaging and have shown marked improvements in B1 homogeneity, even compared to when dielectric pads are used. The improvements afforded by PTX can also be seen in the principal diffusion direction maps. Regions like the cerebellum, ventral temporal, and orbital frontal lobes are greatly improved with PTX. PTX technology can also be used to improve SAR efficiency, which can be used to further shorten the TR of previously SAR-limited scans. In the case of 7T diffusion imaging, this allows for increasing the multiband factor from 2 to 4 to acquire the same data set in half the time. In the last few minutes that I have, I wanted to share some of the upcoming next generation 7T advancements sponsored in part by the NIH Brain Initiative. One of the goals of the Brain Initiative is to achieve whole brain mesoscale functional brain imaging. So 0.3 to 0.4 millimeters isotropic would be great. In terms of voxel volume relative to current 0.8 millimeter acquisitions, that would mean we would need upwards of a 20-fold SNR improvement. Fortunately, most SNR gains from various technologies can be considered multiplicative, so by combining several cutting-edge improvements into the same system, mesoscale functional imaging may become routine in the near future. Some of the technologies being incorporated are high-density, small loop diameter coils, 128 receiver channel systems for improved acceleration with reduced G-factor SNR penalties, ultra-fast and strong gradients for shorter echo times, field cameras, and 16-channel parallel transmit systems, as well as advanced, highly efficient super-resolution pulse sequences. Utilizing just a subset of these next-generation technologies, the multiplicative gains can already be seen in our use of slice-dithered enhanced resolution fMRI in combination with 7T and high-density array coils. With these technologies alone, we were able to achieve robust 0.45 millimeter isotropic fold activations within a single 3-minute run. We also showed that without the slider factor of 2 gain in contrast to noise ratio, it would take 4 times as many averages to achieve comparable statistical power. Using this same combination of technology, we were able to robustly visualize 5 cortical depths of ocular dominance maps, where red means more right eye preference and green means more left eye preference. The last row on the bottom is the average across all depths. This was using a 0.5 mm isotropic acquisition, which is enough for ODC hypercolumns, but will not be quite enough for true columns like orientation columns. With the continued development of 7T technology, it may not be long before we can routinely obtain exquisite mesoscale fMRI data on par with what we can currently see using 7T susceptibility-weighted anatomical imaging, as shown here. In summary, SNR is proportional to the field strength and voxel volume. By combining the longer T1 and shorter T2 star available at 7T, high resolution and higher contrast imaging can improve clinical diagnosis of neurological diseases, as well as basic neuroscience research. 7T MRI attracts cutting-edge technological development for even more SNR, which can be used to further increase resolution or reduce the number of averages while keeping SNR high. These new technologies will facilitate high-resolution study of brain structure and function, like mesoscale computations and gray matter-seeded tractography. If you're interested in getting your hands on some 7T MRI data, feel free to contact me. I'd be happy to connect you with publicly available 7T datasets, or even opportunities to scan at 7T. For those of you who are considering using 7T for your research or clinical imaging, you are in good company. Thanks to the collaborative efforts of my good friend and colleague Dr. Renzo Huber at Maastricht University, we have this publicly available Google map of ultra-high field scanners. To date, there are nearly 100 imaging centers with ultra-high field human MRI scanners, the vast majority of which are 7T with a handful of experimental systems at 9.4T, 10.5T, and 11.7T. A final quick shout-out to the growing number of next-generation ultra-high field imaging centers in the San Francisco Bay Area, including Stanford, UC Berkeley, UCSF, and the San Francisco Veteran Affairs Healthcare System. With that, I thank you all for your attention and give thanks to my collaborators and funding over the years. I look forward to any questions you may have. See you soon.